Unshelling Medicine podcast. Healthcare in the language we understand.
Hello, welcome to another episode of the Unshelling Medicine podcast. I'm your host, and today I happen to have Brad with us to discuss a topic that most people struggle with, but they don't quite know how to put a finger on it. And it often turns into these guessing games that sometimes does not lead to anywhere far. Brad is an accredited metabolic health practitioner. He's also nationally certified. He's a national board certified health and wellness coach. He will talk to us about what that encompasses, entail, what his practice is about, how we can kind of sort of figure out the way forward when it comes to managing ourselves, managing wellness and health in general. So welcome, Brad. It's great to have you here today.
Thank you. Thank you very much and good morning.
Good morning to you. So let's take your title and kind of like break it apart a little bit in understanding why a person in your level of expertise is necessary. We have doctors, we have nurses, we have whoever else practicing medicine. Why do we need metabolic health practitioners? Why do we need certified health and wellness coaches? Can't we just go to the doctor?
Sure. By definition, you would say medical practitioners diagnose and treat. They're great expertise in identifying pathological issues, understanding of anatomy and disease function, and then approaches to treat them. And if I go a little bit back into history here, which we've kind of come full circle, you might know of the story about Rockefeller, a wealthy man in the petroleum industry. So he, at the time, the American Medical Association kind of got together, and who knows what the exact intent was. We hope it was favorable, but the end result was that from the petroleum industry and Rockefeller came medication. And then with the AMA, I guess they all felt it was best at the time to pursue that path. And so our medical system became medication-based. And of course, at the time, they probably thought a lot of the natural path stuff was charlatan-type stuff, and it probably was a little bit. And we certainly didn't know the impact. I think we've learned a lot over the years now of really how our environment, call it food and exercise and circadian rhythm and all of that stuff, plays such a role impacting our, I'm going to call it biological fitness or health. And unfortunately, the education system, et cetera, for medical practitioners was geared in that direction. And I'm sure if you're listening to this, you all know that many practitioners will say, no, I just didn't get any education in nutrition. Which is true, and it's true because of the history of things. And that's kind of shifting around now. You have the American College of Lifestyle Medicine and such that's trying to help with that. And even Texas recently, I think, was looking to pass laws to mandate nutrition as part of the education path of practitioners. For the moment here, what we've learned over such a period of time now, like I was mentioning, the effect of, we call it lifestyle. I like to think of it as hormetic factors from the environment that influence our genes in a favorable manner that makes us biologically fit. And all of those things then include, for example, exercise, for example, sleep and your circadian rhythm and sun and all those natural things. And so that's a whole component, behavioral component. So within what I do, I kind of put it into two buckets: content and behaviors. So it used to be in the past, and many of you might already have this thinking in mind, is that our environment took care of what we needed. So, for example, we didn't have to think about fasting as a healthy thing to do because there was food and sometimes there wasn't. And we didn't have to think about the right foods to have given our geography because we didn't have planes and ships to bring it from Central America. And so our genes over 200 million years naturally represent the environmental pressures where we were for various civilizations, and how that environment worked in harmony with our genes and made us healthy. And so a perfect example, you could think of the Pima tribe. I don't remember if it's New Mexico or Arizona or which state, but there's studies on the Pima tribe showing how they're Native Americans and how they were perfectly healthy. And then as they evolved into our way of life and our foods, they're all diabetic. But take away all that stuff and they're healthy. So here you have this space, which you could say, well, it's all common sense, maybe. But man has created an environment that makes it confusing. So, so foods that we weren't perhaps genetically meant for are in the store, and then we can overeat them, we can undereat them. There are foods that even aren't biologically meant for us, like maybe Pop Tarts or something. The population just assumes, well, it's on the shelf. The
Right.
FDA says it's okay, so there's no problem eating them. We have Netflix on the TV at night. I don't know of any reason why I shouldn't be watching a late show up till 12 a.m. And so we have all these environmental things and nothing to guide us. It's like we're on a road with no guardrails. And so inherently, what can happen is people can just progress in this environment, which they have no understanding of how to navigate it because we've modified it by so much and introduced so many things that aren't favorable. And some things it's the dose. My business is called Hormesis Health and Fitness, and you might know has to do with hormetic factors. Certain doses like eustress are healthy for you, whereas other doses can be bad for you. So things are in the dose, obviously, but so consequently, what can happen is people can go through these periods of time. And by the way, for example, you might know that we can detect characteristics of type 2 diabetes up to 20 years in advance. So how is that possible that we can note those things now? If you flip that another way, you could know that those characteristics exist and grow over 20 years and until finally they have perpetuated themselves and become apparent enough that it warrants a diagnosis. And if you look at people right around age 50 or 60, many are on many medications, 2 or 3 medications. And so if that wasn't something that just happened overnight or over a week or month, it accrued over time. And have a piece that illustrates it over 7 stages. It's the progression of insulin resistance. So if you consider the last stage is irreversible organ damage, but maybe let's go with that's stage 7, but let's talk about stage 6. That might be where you're on several medications and kind of a difficult physical health, but you can back it up from there to maybe the second stage or so where you have difficulty with weight around the belly, or you're tired after you eat, or you're beginning to see your blood pressure rise. That's the beginning, if you will. So, and that's all a function, I would say, a large part. I'm just going to really talk about a mismatch. A mismatch. It's a mismatch of our environment that we created, which is now so mixed up and random that ultimately it confuses our genes, for one thing. And so, I mean, a person can wait, from age 30, 50 when they get that diagnosis, and a physician would be involved. Or they could get involved earlier to, one, become educated about this. And I like to call it prehabbing your health. Become familiar with what your genes need, learn how to navigate the environment to encourage your health in a favorable manner rather than it working against you. Now, so then for many people now, right, 91% of the population are metabolically unhealthy. That's unfortunately, as a coach, I work with a lot of coaches, and we all have our own style, and many coaches will kind of bring it out in a soft manner and talk about it easy and one piece at a time. I don't know. It's just unfortunate for me. Maybe I need a coach, but I can't help but come out in a strong manner, hard and significant, because it is such an important and overwhelming problem with 91% of the population metabolically unhealthy. It just needs to be highlighted, and change only happens based on a discrepancy. And then obviously the magnitude of that discrepancy is how quickly and how significantly we lean into it. And so here I am trying, being a little pushy or powerful in what I see since sometime before 19, right? The McGovern Committee and looking to change the, fats cause heart disease, that whole thing, right? Right at that trend, you just saw obesity incrementally escalate, diabetes incrementally escalate. So it's been over 4 decades now. And now we have to deal with the consequences of all of that with the people who are at that peak, as well as hopefully not let everybody climb that ladder. But so you have all those people that are at that peak, and now they will be diagnosed and they will need to be treated. Initially, you have significantly high blood pressure, that's at risk. You have A1C of 10 or 12, that's at risk. And so that has to be treated. But at the same time, in my opinion, I think it's important to recognize what the body still needs, what the genes still need. Call it the foundation. Still needs these certain types of foods. It still needs, call it a foundation or a platform. And the body will thrive when it exists and participates in that platform, that healthy platform. It will thrive in such. So we have some people that are getting to the point of medication, but then we need to get them into that platform, help them ease into what the body needs and eliminate what it can't tolerate, like in terms of toxins, and then demedicate them. So the most important thing I think I see now, a couple phases, a lot of people are at that peak, which has no alternative due to the risk to have a diagnosed and treated. But we would hope that we can recognize what that foundation is where everyone's healthy and still prioritize that into the plan and then with the skill of the practitioners to help get them demedicated and into a health frame again. So I think the coaches can deal very well with lifestyle and such. And I think right now there's an opportunity. There is kind of a chasm because, to be honest, in the past, there's a lot of scope of practice. There's a lot of stay in your lane. And I think it's forced a lot of coaches to just be really careful and not use the word food or not use any term, maybe not even use the word health because of the implications. And so we've been, stratified way over in the corner. And now I think that in many clinical studies, the first phase of treatment is lifestyle. And the second phase is lifestyle, perhaps. The third phase is maybe lifestyle with medication. Fourth stage might be more medication. But anyways, we hope that in the beginning we address those things. So what do coaches do? So you could say the content or all those, call them basic lifestyle things, but I would suggest that people now in this hugely mixed up environment need the guidance, even through sleep, even through food, even through exercise, etc. Because all of those things can be used a little more strategically. There's certain I'll give an example. So we often talk about it's an easy point of entry for patients to walk, and that's a good thing because it has its own health implications for helping the health of the mitochondria, the energy factories you have. They benefit from a walk. But then also, if you're type 2 diabetic, you will hugely benefit from strength training. Hugely benefit from strength training because if your insulin receptors, for whatever reason, aren't connecting well with the insulin, it's not working well, the contraction of the muscle, they call it mechanotransduction. To be technical for you folks, maybe they'll look it up, right? So it activates what they call glucose transporters, and in the muscle, it's GLUT4. So it activates GLUT4 rather than insulin normally does that. But when you're insulin resistant, that doesn't happen. So the contraction of the muscle makes that happen. So contraction of the muscle, not only is it natural, it's built into us for this purpose, but it's also recognizing it does that can be a therapeutic strategy to helping people with blood sugar that becomes irregulated. Even people who have dawn phenomenon, for example. I can tell you they're in one of the metabolic archetypes maybe we venture into at some point, but genetically, certain people, their genes are such that they will show the characteristics of dawn phenomena. So it's built in and it's natural and there's nothing wrong with it. But you can also kind of reduce the effects of it by the diet you're on. And you can also use the proper strategic type of exercise and time it, and it'll mitigate the effects of dawn phenomena. So overall, if you go in for your appointment, person goes in for their appointment in the morning and they have high fasting glucose, maybe it's 110 or 120 like my wife might be, but her A1C is like 5.5. So if you look at averaging things, you look at maybe in the morning, you might have a significant dawn effect. By 4 o'clock, her fasting glucose might be 80. And so I'm just using that as an example of how like food and exercise, we talk about them generally, but I would offer with coaches, in the case like my background, you can be more strategic with these things and have an actual therapeutic effect within our scope of practice. Then you have the practitioner who's monitoring the A1C, running the labs, helping to bring down their medications safely. And now you really have a partnership involved there. Not to mention, you could talk about some of the cliche things that practitioners don't have enough time. That's true. Some time back, I saw an article about we don't have enough doctors. They're all run thin. That's true. And then so there's the concept that use your health and fitness coaches to help with that time. So there really does need to be a partnership. I'm saying there's a tremendous opportunity to have a partnership.
The partnership and collaboration. You did say it the first time, there needs to be, it is much needed. I know you kind of like reset it in a way that seems more palatable. Thank you for doing that. It's a shame that you had to do that, but thank you for doing that. I think more than anything, we need to put ego aside and recognize that one person cannot be everything for everybody. The doctors are working very hard. They have their own career, a responsibility to fulfill, as well as the ethical responsibility to fulfill. It's a lot on one shoulder or group of shoulders when the capable people to support the initiative of this journey of being human. Science is science, experiment is experiment. Whatever the outlook was initially when things were put in place, we're starting to see that it maybe was not the best decision, or maybe a few things need to be tweaked. It's of benefit to tweak it and to work together. Where one falls short, the other person can be knowledgeable. This is why we have interdisciplinary team effort. The patient treatment times, unfortunately, you see that really heavy in a hospital setting, which is kind of like reactive in nature. Right? So at this point where a person is at almost rock bottom, let's try to bring this person back up to the surface. However, if we had the same level of interaction and collaboration out in the community, this person hitting rock bottom or close to rock bottom will be drastically reduced. That the chances of that happening will be drastically reduced. I am of support of the idea of the need to collaborate, the need to work together, the need to hone into each other's expertise, because it is absolutely necessary. That's why this platform is very much solution driven. Yes, we know the cracks in the pot, the cracks in the system.
Yeah.
Where do you come with your own expertise? I think we've patched it for long enough now. I think we need to kind of like rebuild it in a sense. So thank you for saying that. About your journey, how did this journey start for you? Because often when I talk to change makers, when I talk to innovators, is usually as a result of their own rock bottom. How did this journey start for you, Brett?
Sure. Maybe a few data points. I went to college for a short period of time, and then just felt that I joined the Navy. So I was on a ship. I was in Caribbean a lot, and the Mediterranean a lot of sun, and it's beautiful, like a cruise ship, only gray with guns on it. But anyways, but where I'm going with that is it started when we didn't work. We got a weight set from the commissary, and we worked with finish and we worked with weight. So I kind of got involved with health and kind of knew what health felt like a little better then. And then I hit shore duty, and a lot of responsibilities there. All that habit disappeared. I was just working, and so it kind of disappeared. Then I left the service, worked for a number of industries, worked for Philips Medical Systems, medical imaging for a long time. At a point, I had to commute like an hour to get to where I worked. And it was in Connecticut. I don't know anyone familiar with Connecticut. I drove down 95, which is on the coastline. And when I left my house, about a mile down the road, my breakfast was a large Dunkin' Donuts coffee with cream and sugar and an old-fashioned donut, those greasy ones. Yeah. Well, I tell you what, that sugar and that grease and all of that tastes really well. And of course, then the sugar builds your energy and all that. So by the time I got an hour done driving, I was at work. Thought I was ready to go. So I did that for many years. And then, of course, the stress and things, I think stress played a huge role in what happened to me. A point there, I couldn't gain any weight. I was thin. I was like 135 pounds soaking wet, which for a man meant I was probably about, my lean mass is probably about 100 pounds, very thin, didn't know why. And for whatever reason, when the companies changed health insurance and I had to find a different practitioner, it was an internal medicine person, very sharp. He just ran the tests for antibodies for celiac disease, and I had celiac disease. There we go. But actually leading up to that, before he ran that test and I knew that, I can tell you where I was working at another company before that. It got so bad that And it used to be when the VP of marketing, the COO walked by and they saw me sitting in my chair on one of those blow-up pillows because my hemorrhoids had become so inflamed because of all the inflammation and such. I guess trying to help me out. They're kind of laughing and such because of the pillow, but that's where it got to.
For people who don't know what celiac disease is, can you just expand a little bit on that?
Sure. So celiac is, and there can be sensitivities and there can be the actual immune function antibodies generated. I have a disease, celiac disease, which is the antibodies are involved. And what it is, it's an allergy to gluten. Gluten is a protein, but it's predominant in grains like wheat and many other grains. Here's an interesting point about that is that it is predominant amongst Caucasians of a Northern European descent. So you might say Norwegians, Swedes, go far enough back, you could think Vikings. But anyways, those people probably didn't have a real agrarian, grain-based diet. So their genes had no need to tolerate gluten. So if you happen to come from that background, and it was in my case, then I don't tolerate the gluten from the grains and such. And that's what I needed to do, is eliminate gluten. There are a lot of organizations you can look up related to celiac that can give guidance on how to test for it, what to look for, and as well as what foods and things to avoid. So that was celiac. And then because I was really feeling kind of bad, now that I knew what the obstacle was, I was on a path of health. And that involved eating the heck out of, because I was only 135 pounds, that involved eating the heck out of foods, a lot of protein. So I guess for me, and it's kind of psychological to be at that kind of level effectively, it was a matter of then rebuilding my body, especially for a male, of muscle. So I was at the gym a lot. My goal at that point was I already knew how to not have problems with my gut and not feel well there. But then it was regaining, I guess, my physique. And so it was a lot of gym work and a lot of consuming a lot of foods and proteins, et cetera. And that happened over. So bottom line, I put on 60 pounds of lean body mass. That took me up for lean body mass from probably around 100 up to 60 pounds of lean body mass. And at one point, I actually overshot it. I figured if I just keep eating and keep training hard, I'll get as big as Arnold or something. And that was not true. So I got to about 222 pounds. And that was over a journey from when I was about 40. So along the way, some friends that I trained with, it's great to have a partner when you do these things. They can be motivating and such. And a few of them were familiar with training and bodybuilding. And they said, hey, you should try bodybuilding. So eventually at age 52, I did. I said, fine, I'll do it. But the thing was, I kind of had a strategy, which is a little long description, but I wanted to do it right away. And so the closest one was only about 8 weeks out. And what I found is that I actually had about 30 pounds of body fat, which I didn't need and wouldn't be favorable for competing. So I gained that 60 pounds of lean body mass. And in order to prepare for the competition, I had to lose 30 pounds of body fat. Well, I did that. And in the process, I didn't lose any lean body mass. So that was in 8 weeks. So that's almost unheard of. During that process, I learned a lot. So for everybody, I actually followed a targeted ketogenic diet. It was ketogenic, which optimizes loss of body fat from your fat cells and metabolizing your fat. It's the most optimized method. And it was targeted, meaning to train, to help resistance train and avoid loss of lean muscle mass. It was targeted, meaning I would have a small quantity of carbohydrate just before training. But 8 weeks, loss of 30 pounds body fat, no loss of lean mass. And so I learned a lot about how to gain muscle. I learned a lot about how to lose body fat efficiently and effectively, more so than many other things. So if you look now, basically what I did with the loss of body fat, you could look to Virta Health. Some people might look that up, VIRTA. They're a big company that helps care for type 2 diabetics. And the authors or the originators, Dr. Stephen Finney and Dr. Jeff Volek, a couple of great guys that originally were founding, and then someone came along and created a company, and they're all in there, and they use ketosis as their approach. But anyways, so I learned a lot about that. So fast forward a little bit, then, well, I guess fast forward a lot. I met my wife, And so at the time, my wife was a type 2 diabetic. At one time, her A1C was 10. I don't remember what it was when I met her. It might have been a little less because I think she was on metformin. But she was on 6 medications. So you got medications for the sugar. You've got medications for a diuretic for holding on to water, because that's what will happen when you have high glucose levels. She had so 6 medications, and she was a size 16. So diabetic, 6 meds, and size 16. So at the time, we just did what I knew to do. We trained, we weight trained regularly, 5-6 days a week, and she followed a ketogenic diet. Her diabetes went into remission. I think at one point it was down to 5.2, and she came off all 6 medications, and she dropped 12 dress sizes to a size 4. While this was happening, she obviously went into the medical practice for her regular appointments, and her practitioner was saying, "What are you doing? What's going on here? This is kind of amazing." And so we talked about what was happening, and they had a lifestyle clinic that they were running. I guess the person had left, and so the provider, who was a co-owner, said, "Would you like to work here?" I said, "Sure." So then I came into the practice. I was there for over 8 years and directed the lifestyle clinic. So that's when then there was even more learning that happened, because now I'm in a clinical setting. I'm seeing all the people who are diabetic, who are pre-diabetic, who have high blood pressure, who have high triglycerides, and all of these things. And as a consequence, my curiosity always gets the best of me to look into these things. And it did so. So I learned a lot about this whole picture of metabolic health, about insulin resistance, about the relationship of triglycerides to causing, it's a pattern, but the relationship of triglycerides to causing your LDL to be small and dense, and then be a factor contributing to atherosclerosis. And then the notion of high blood pressure, it's not just cholesterol that's the problem with atherosclerosis. It's small, dense particles. It's oxidation in your body. It's inflammation in your body, and coupled with high blood pressure on the tissues. But actually, the high blood pressure and such, and sugar. I don't know if people know this, but the glycalyx is a protective layer. Call it like a set of hairs over your arteries, and it's protective. And high levels of carbohydrate or glucose, call it continuous glucose there, literally flatten them out. And now if the glycalyx is flattened out and there's no barrier, call it a Bush barrier, then if you have small dense LDL particles, that makes it even easier for them to get to the tissue, coupled with high blood pressure. And it's just inevitable that you're setting the conditions for atherosclerosis. So it's kind of an amazing thing, but to see this whole picture and understand how the body works metabolically is amazing. Like, your triglycerides and HDL have kind of an inverse relationship. As triglycerides go up, HDL comes down. And so as I began to understand this, I understood these patterns. And ultimately, I'll just mention one of the metrics that I've just become so favorable with is the triglyceride glucose index. You'll often see it noted as capital T, small y, big G. And it's a formula. There's clinical studies on it, et cetera. You can find them. I have a calculator on my website because it's logarithmic. I'm not doing that every time. So I use the calculator. But it is a way to see insulin resistance, or the propensity for insulin resistance. So the way I would do that is patients would come to the clinic, be sent over for weight loss. And I inherently came to the mindset that, yes, there is weight loss, calories in, calories out is a factor, but predominantly, and everyone in the clinic, it was an issue of insulin resistance, which was causing this whole pattern. And then the weight was just another symptom of this problem. So before they came into the practice, I'd look in the health record, the EMR, and I'd look up their fasting triglyceride, fasting glucose, run it into the calculator. It would come back with suggestive of insulin resistance and highly probable for fatty liver disease, right? Because that's a component in there. Normally, you'd have to have an ultrasound or whatever to see those conditions. Maybe you could see it with other liver tests, but conditions happening in the liver, it's just a very simple thing. Almost everybody has fasting triglycerides and fasting glucose in their health records. So just drop those in. I already know what's happening before I even talk to them, which is kind of a problem because I'm already ready to tell them what to do which isn't a good thing either. But I already have a sense, and so I know how to kind of navigate the direction as they're ready for the conversation and such. But if I can tell a quick example. So I had one woman, I think she was in her 70s, early 70s, 71, very tall. She wasn't overweight, but she came in, she had triglycerides of like over 250. So, again, I didn't even really need to run the triglyceride glucose index to know that it's probably an issue of too much carbohydrate. And by the way, even high triglycerides could be an indication of familiar hypertriglyceridemia, right? Too. But even if it is, I believe from clinical studies, they suggest one of the best approaches is a ketogenic diet and reducing the carbs as part of the treatment. So even if I'm off on the index, the approach is still the same. The funny thing is, I show them this index. And I say, okay, so you kind of see what the problem is. And now let me explain how this kind of relates to your overall health. So as your triglycerides will go up, and that relates to then causing smaller dense LDL particles, which can put you at risk for atherosclerosis. And then I also had a simple calculator for the atherogenic index of plasma. You can look that up. There's a calculator. It was real easy. I put in the triglycerides and the HDL, and it would show that. And so that was an interesting thing to kind of connect from the atherogenic index of plasma and the potential for contributing to atherosclerosis, bringing it back to triglycerides again, and then being able to talk about how carbohydrates and all that can affect this whole system. So funny thing is I'm describing some of these things, and she says, I don't need to know this. Why do I need to know this? Just tell me what to do. I'm like, okay, we'll cut out your carbohydrates. Now, that wasn't the most brilliant coaching moment,
Right.
but then she says, well, why do I have to do that? And now I'm back to explaining what I was explaining. Right?
People see it as boring. Again, we are very much in the society, the delayed gratification aspect of life is not what is common in the Western world, especially in the United States. It's kind of like, get to the point, tell me already. I think that is one of many reasons why people do not adhere to recommendations, especially related to healthcare. Because if you don't understand it, it's going to feel like just another thing to do. However, if you understand the implication, the ramifications of either doing it or not doing a particular thing, especially as it relates to lifestyle change, because when we're talking about lifestyle change, we're talking about habits that we have gotten used to either since childhood or familial in nature, because those habits get passed down. So if I don't understand how the ingredients in drinking a 12-pack of soda, daily, what's in that soda? How is my body reacting to it? What are the benefits if I stop drinking it? Or what could possibly happen if I continue drinking it? They say the devil is in the details, but the good is really in the detail. And sometimes people find it boring or find it mundane, and just get to the point. Just tell me what to do. Get it over with. Yeah. I get it, but you have to understand. If I don't understand what I'm doing, there's 90 to 98% of assurance that I may get something wrong. It's kind of like the only thing that I can think of, you talked about the military, when there's a threat of a bomb or anything, you call the specialist in. And they do know, hey, I have to grab the right wire or do the right thing to not set this thing off, right? So if they were not paying attention to the importance of cutting the right wire, they'll just go in there and cut anything, and boom, bad things happen. So that is very common. Just tell me what to do, but why am I doing this? Okay, let's go back to what we started. Yeah, that's a common occurrence, and I think it's very societal in nature.
Yeah. I really appreciate what you just said. It's so true. And often, and I think our culture has perpetuated this thing. If you want to be healthy or this health aspect, you just need to lose weight. And that's, well, partly true.
What is healthy? That whole conversation. If you want to be healthy, you have to lose weight. So what exactly is healthy? You mentioned keto diet. Keto has been controversial, has been helpful, has been a trend. So The thing with society, and especially with the American society or the West, I wouldn't say Western because that's really generalizing. I'm going to specifically talk about the American society. We find things out and then treat things as a fad without really understanding the nitty-gritty of why we're doing this. Maybe an influencer or somebody peddling something picks up a few pointers and uses that to market your product. These are just a few points that you know. Do you know a little bit more than just what this person said? Almost everything is a fad. You mentioned celiac disease. You mentioned sensitivity to gluten. There was a time where gluten-free was the thing. Everything was gluten-free. Everybody wanted gluten-free water. The silliness behind it all. Yeah. And even people with celiac disease were like, okay, you guys are kind of like glamorizing something very serious. This is a serious disease process. This is a serious diagnosis. So I think the fetishization of health as opposed to what health really means is what kind of like dooming us in a sense.
Right.
Because what is that? What is healthy? Because healthy for you is different from healthy for me. Because of cultural nuances, cultural differences, genetic differences, familial differences, lifestyle differences. For somebody who commutes to work, either by train or by car, that's two different lifestyles. There's the commuting. Somebody that's working from home, very different from somebody that is very handy using that either a round saw, whatever saw to cut whatever wood or metal. So health is very individualized. So that buzzword drives me insane because we're very different in what we need to be healthy, and we have to get to the bottom of that. So given what you do, how do we get to the bottom of an individualized plan of care? This is me pulling my nursing brain into this. An individualized plan of care when it comes to health, managing not just weight, managing what your body needs, what your DNA requires of you to be healthy.
Right. So what is health? That's a key part of it. And I just have to, I hope I don't say anything that offends the audience, but if I do, I don't intend to. It's just my own bias or opinion. I will not use the word health anymore because health has been set up to imply that if, for example, you have high blood pressure and you take a medication and now your blood pressure is in the normal range, you are now healthy. No, you're not. You've used a pharmaceutical to circumvent the issue. So I'm not okay with the idea that we call that health. And so now that's where I talk about this notion of biological fitness. So now I have, you have the people who maybe don't want to be CrossFitters necessarily. And then you have the people that believe they're healthy and then eventually might be treated by medications. What is it that you talk about for all those people in the middle? And for me, without going past my scope of practice, I am calling that biological fitness. And I'll give an example, if I can, quickly. HSCRP is, probably everybody knows what that is, high sensitivity marker of inflammation. So with most labs, they will show that between 1 and 3 is normal and above 3 is high risk, especially related to cardiovascular disease. Here's the thing. So how do they determine those normal ranges? So the labs, like LabCorp or Quest or whatever, they get their samples and they cut off 2.5% on the bell curve on one side, 2.5% on the bell curve on the other. So now you're left with 95% of that population. That population doesn't include probably people with heart disease or something like that, but that 95% includes people who are metabolically unhealthy. Why? Because 91% of the population is metabolically unhealthy. So if 91% of the population is metabolically unhealthy, and you go out and sample 95% of that, you're getting metabolically unhealthy in that population. So we know that, for example, if your HSCRP might be like 1.2 or somewhere's in there, you can run a test like maybe the HOMA-IR, which is a marker of insulin resistance, or even the triglyceride glucose index was pretty easy. And you're probably going to find that they're approaching the beginning stages of insulin resistance or more. And so you have this insulin resistance thing happening under the hood that these definitions of what's normal totally overlook. And so it goes for years. Remember the 20 years, it goes for growing in the pot on the stove, stewing for 20 years until finally we qualify, the bell goes off because the A1C hit that goal line. And I will only use biological fitness anymore. When it comes to HRCRP, and there's studies for this, they talk about optimal being on the far left being less than 1. So when they say optimal, they cue everybody in to think, well, that's athletes and health hackers. Like it's not a place that anyone really needs to be. You're okay being in 1 to 3. So they discourage people from acclimating below 1, even just by the messaging in the labs. And the fact of the matter is, when a person gets their environment, and it can be different for different people. That's where I have these archetypes that I could talk about. But when your environment matches what your genes need, you're not going to have high oxidative stress or high inflammation. My HSCRP, I remember the last time was 0.6. My wife's, remember, she was type 2 diabetic and all that stuff. She is down there too. I think she was 0.5. So that's not health hacking, and that's not an athlete. All she did was match her environment in terms of the food she was genetically made for, the exercise she was genetically made for, and everything fell into the spot where her body functioned properly. And an example of one measure, the HSCRP, put her at below 1 easily. And she's been there for over 8 years. So that's just one example. And the reason I won't talk about health anymore because it includes the notion that, again, like if you're on a medication and your metric is in the normal range, you're okay. No, you're not. It's just a way to keep people thinking that they need medications.
It's just the successful management of symptoms. It's not addressing the root cause. So we've successfully managed the symptoms that presented. So if you are diabetic, a type 2 diabetic, and you were prescribed insulin of whichever variety, you have your fasting finger sticks, within a certain limit, and you're well managed, or A1C is well within, the therapeutic range, whatever it is for you, you're well managed. High blood pressure, like you mentioned, even asthma. So I'm just going down the list of some chronic conditions that can be addressed. So the health part is not that the root cause has been taken care of, is that we have successfully managed the presenting symptom, because at the end of the day, most of our practices is focused on first, especially when somebody presents in the hospital. If somebody presents in the hospital with a symptom, lifestyle is going to be the last thing on the medical doctor's minds. It's basically, this is what you're presenting. This is what we have to address. Let's focus on addressing this presentation. And addressing the presentation and getting you to baseline, whatever that baseline may be for you, or therapeutic baseline, is successful. So I think that is where things kind of like get mixed up. So when you said health, that's why I had to, what do you mean by health? Because it is such a broad umbrella that we don't have to have.
Mm-hmm.
Broad umbrella that a lot of things get kind of like jumbled up and lost in. Health is what we do with discharge planning in the hospital. How do we make sure we maintain this person outside of the hospital for more than 30 days? So we meet that quality measure set by HEDIS, and insurance can pay for them in case they have to be re-hospitalized. How do we keep this person healthy in the community? And it shouldn't stop there. I think that is the message, because we've successfully addressed the symptom, right? In the hospital, on this presentation, on this admission, doesn't mean we stop there. Yes, we set up for safe discharge. There should be collaboration with community-based coaches, with wellness coaches, with health and fitness coaches, whatever it is. Anybody that has a proven track record, anybody that is knowledgeable and certified, because we in healthcare were big on certification, anybody that is certified and has the experience of supporting people in the community in a way that benefits not only the person, but also, the healthcare community as a whole. Yes, there is success in managing the symptom, not necessarily addressing the root cause. We also manage the root cause, but sometimes there's a little more needed that the doctors just cannot do, because, again, they have so much responsibilities to shoulder.
I have one example I'll give, and then I'm going to go to where I intend to get to, and that was with patients. Food is a difficult thing. It's like religion and various other things. So inherently, it's challenging. And so inherently, like I said, everyone walks in the door. They all have levels of insulin resistance and such. I know that's the issue. I know that reduction in carbohydrates will help with that, but that is so delicate. And so, as we talked about the why earlier, a person may think, well, these are just diets, and I could choose this diet or that diet or this diet. Well, not really if you look at the diet and its effect on your insulin sensitivity. And so that's why I tried to expand it to show relationships, as we talked about more, to expand the why. Like, okay, so you probably don't want atherosclerosis or heart disease. Well, no. Okay. So you see how the triglycerides relate to your carbohydrates, right? Yes. Okay. So I'll even say at some point, I'll say, look, in my coaching time, I've even gotten to the point where I can say, you can eat whatever you want, but I think we can agree these metrics right here, the consequences when these are out of alignment, like your triglycerides up here or your atherogenic index of plasma or whatever, I think we can all agree those are pretty important to things you don't want to have happen to you, right? Well, right. Okay. So let's just use these metrics and let's see how it goes then. And so they can take it upon themselves in some cases to do that. I just hope that I can elevate it from rather than just a description of foods to the goal on the outcome that we're really concerned with, and give some metrics that help us know if we're there or not. So that would happen. And with some people, just like that woman, we go from 250 with triglycerides down to below 60. I know that woman was elated regarding all of her health. But so anyways, during my coaching, I think there's a lot of things you can measure.
Yes.
And I was trying to think, so what might be. And
I wanted to mention something about food, because you said something in the beginning and you said something again, and you're going to go on your point. I think it is important for us to understand, this is not just the medical doctors, this is everybody. I think it's very important for us to understand that DNA does not most time make mistakes. That there's a lot that is hidden. We are still discovering all of this. There's a lot that is hidden in our DNA, and also geographical area plays a role. I'll use myself as an example. I was born and raised in Nigeria, and I have been very fortunate to see people live well into the hundreds. And the primary oil we use in our food is palm oil. So you have a combination of, the foods, a combination of foods, the herbs, the vegetables, the everything, the activity level, and then the sun, right? And for somebody like me, who's now in the United States for, past too many years to count, right? I cannot eat the way I'm used to eating back home without ballooning, because my life here is more sedentary. Not that it wasn't back home to a certain degree, but my life here is more sedentary, and also the weather changes. I cannot be an accurate representation of a Nigerian. And I'll say that again, DNA-wise, I cannot be. Because what our bodies and DNA kind of does is that it manipulates itself to kind of match an environment. It's been there for a prolonged period. So if I was to go into a clinical setting, I will match perfectly a Nigerian in the European world. However, I cannot be a representation for Nigeria in Nigeria. So this is why we're not a monolith. The same way I will not make an accurate representation of an African American who have descendants from slavery. The same way I cannot represent whatever a Caribbean Black woman, right? I can't fit into that mold again, because there's so many nuances to our DNA that makes us so different. Going back to foods, what you said about the Native American is that their traditional diet was great. It sustained them. They lived healthy lives. However, with the exposure of European foods, we're talking pasta, we're talking pizza, we're talking, not to pick on Italians, I'm very sorry, guys, but we're talking all the other foods that are not additional to that culture. It alters something within you, and something within you is not going to agree with it. So when we talk about, or when you mention nutrition, I want people listening to us to understand that this is a big deal. It's not just food. And your body is going to fight you if you try to force it to adapt to nutrition or food that your DNA does not completely agree with.
That's correct.
That's the point I wanted to make. Just go ahead.
That's correct. That's absolutely correct. Yes, since you highlighted that, I'll finish off the one point and then come back into what you're just describing here, because that's so true. Inherently, I have two levels of labs now. One is a level 2 and a level 1 and a level 2. So the level 2 gets into, for people with weight loss, it checks kidney function and liver function and some other things that obviously have to be in pretty good shape to allow metabolism and various things and weight loss and health to happen optimally. So that's a more detailed level 2 set of tests. My level 1 test, I thought for quite a while, how can I pick some metrics that would be summative of things that might be happening below? In other words, I could just kind of look at a dashboard and they would be representative of whether or not I needed to dig deeper regarding metabolic health. So here's the ones I came up with for now. The triglyceride glucose index, because it is the most sensitive for knowing peripheral insulin resistance. Even before labs like, I know Quest has a test called insulin resistance with SCORE. I found that when I was in the practice, that was not detecting insulin resistance, but the TYG was. And I believe the difference was that for some patients, and I believe the difference is the triglyceride glucose index will start to detect insulin resistance happening at the muscle and liver before the pancreas and the rest of the system starts to get heavily involved. And my goal was to help people change early. I mean, that's a good diagnostic tool, I think, the Quest test, but I want to find it sooner. So that was the triglyceride glucose index. Next, I used, if I remember them all, HSCRP for inflammation. It also can be indicative of a number of things, including insulin resistance, etc. I used GGT. Don't ask me to describe what that is. I don't even remember, but I know that it's reflective of liver function, but specifically it can be analogous to oxidative stress. So now I have oxidative stress without testing some other crazy oxidative stress. I have oxidative stress, I have inflammation, I have insulin sensitivity or resistance happening, and then adiponectin from fat cells, which is indicative of insulin sensitivity. And then I can't remember the others. I think then I'm just looking at VO2 max or something like that. It's just some high level things from a metabolic function that if I watch those, I'm pretty sure that I'll see if we're drifting, and that would be a biological fitness look. And obviously the level, the range is different. Like I said before, HSCRP, it's going to be less than 1 as an example. So that's my level 1. And that's what I hope everybody to aspire to. And I believe that regarding, so now I should lead into the archetypes and the discussion of genes. I believe, so there's 5 archetypes of which I'll describe them, and they are representative of gene profiles, unique profiles. And I'll come back to that. But I believe that when a person knows which archetype they're suited for, which is simply a reflection of their ancestry and the genes that they brought with them, which is a reflection of where they came in the world geographically and the environmental pressures that formed those genes over 200 million years, not the last 100, that when we can help a person determine their archetype, that when they introduce the proper environment to it, being the right exercise or foods and sleep and all those various things, when they introduce that, which matches the needs of those genes, that we see the biological fitness metrics, those labs I mentioned, come into biologically fit levels. So that's kind of the big picture thing that I have going on. Now, so for example, I'll try to remember here, there's 5 archetypes, and I think I can describe them pretty succinctly. But the key point to understand is that they represent gene makeup from ancestry, if you will, from climates and geographies that, call it environmental pressures, and there's other aspects, determine the gene makeup over 200,000 years. I think if we say the body's pretty smart, it doesn't make anything that isn't essential for it. It doesn't do that. It doesn't put a lot of chrome and leather on that car. And also, it makes sure it has what's necessary for that environment. I mean, it puts a big engine in there if it needs it. And if it needs a 4-cylinder, it puts a 4-cylinder in there. So it's pretty specific in how the body is made. So if we go for that for a moment, then we could believe that the genes that are there are representative of nothing more and nothing less than the body needed to survive in that particular environment of environmental pressures, et cetera. and over 200 million years. And then we could also look at, well, how quickly can our genes change? I've done that. I looked back. I think the quickest some of the genes would change would be 10,000 years. And so I made an analogy, I think one that most people can understand. If you just look at milk and lactose, that's one example. If you look at another, I think for your background, I just made it as one of the simplest, easiest to appreciate examples, I think. So populations that came from more central equator, your skin color helps protect from the more intense UV rays. It's an adaptation, a positive gene characteristic. Now, yet, so you move to New York. Okay, how come in a year you didn't turn white? You know what I'm saying? Why would we expect us to be able to change our diet on a dime when other aspects of our genetics don't change that quickly? Honestly, so I think it's fair to say that these genetic profiles are pretty reliable. I also looked up the idea that we have immigration and we move around the globe now. Populations move along the globe. There's a proper archaeology, genetic term for this. So we're becoming intermixed. You could say, well, the archetypes aren't going to be real because we're getting all mixed up. And to some extent, that's true. But the best estimates I have is that it's going to take, from the fastest extreme, it's going to take 3 to 5 generations before our genes are so mixed up that you couldn't call things profiles. So the notion, well, we shouldn't do that because we're getting all mixed up. I don't know. We've got about at least 3 to 5 generations that we could benefit from. I think we ought to do it.
Mixed up. I don't know why people fear mixing, and I don't know why people fear of unknown is a human thing, but people have really expanded it to levels that is very cringy. We're all going to mix. It doesn't matter how. Even within the continent of Africa, the 54 countries in Africa, some of us, if we lean into the DNA testing, we'll find that we're pretty spread out and ancestry-wise. So the immigration didn't start today, didn't start yesterday. It doesn't only start, like it didn't affect America.
Right.
America's a unique country, right? Now, so within Africa, even, I mentioned myself as a Nigerian American and not being a great representation of a Nigerian woman currently living in Nigeria. How does whatever medication, diet, or whatever affect a person of that DNA makeup? Even with that generalization, I cannot be a sole representation of Nigeria because we're tribal people. We eat very differently. Right. Our lifestyles are very different. Cuisine are very different. Our practices are very different, although similar, but different, right? We speak 250 languages in one country. So see, that's how different we are. I think it's just laziness of sort when we lump people or group people as a monolith, when it really disregards the uniqueness that we all present. It really does disregard that. So to do a clinical trial and say, we need an African-American woman of what descent?
Mm-hmm. Mm-hmm.
You really delineate that, although there are similarities, we're not the same. We're not. Right. And this is what we find in drug efficacies. When you don't do the proper work in the beginning, you run into issues. You run into experimenting on humans when the experimentation should have already happened. And we know how this would affect a person. So doing the work from the very beginning and understanding that we may be similar, however, we have different nuances at the DNA level. I'm not just saying my preference as a person, but at the DNA level of how a drug would affect me as opposed to an Ethiopian American, as opposed to a South African American, as opposed to a Moroccan American or Egyptian American. And then we come to my African American cousins and brothers and sisters. A person from the South eats very differently from a person in New York.
Right.
I'll go to New York. Yeah, we share a love for pizza and Italian culture and things about. But even with that, we're still arguing about pizza, deep dish versus, again, nuances, differences. And it's just, this is my sounding board to anybody listening. it is your responsibility to make sure that you're treated as an individual. And when you talk to your doctor and you have like a paintbrush approach to your treatment, if you can reconsider finding another doctor, please. I think we will really get to a point of making great advancements in healthcare when we really practice that individualized plan of care, as opposed to, using it because it sounds good and is great with marketing. So yeah, what you're doing is great work, Brad. And, talking about it, and not only talking about it, but also showing, a successful track record of working with people, including your significant other. I think more and more people have to hear this, because more people think about it, but nobody wants to think that they're crazy for overthinking.
Yeah. So maybe I have plenty of time. I don't know how much time you have. And then, so I think I'll be on the same path as you, maybe something the same and that's slightly different, but in terms of the grouping, and I don't mean to be contradictory either in any way, because we are different. We are different, and I'll back it up a little bit. And
Right.
I guess my question would be, do you think it would be, I don't have to, but I do have this visually. Now I could describe it, or I
Right.
see you have a screen share. I could share if you want to attempt that, or I can try to talk
Yes.
through it, which
For the benefit of the people who are just listening to us and not able to see it.
Okay. All right. So here's the thing. There's 5 archetypes, and they're profiles, but I'll try to give you a quick first cursory of each of them. And then what I'd like to do is tie in my wife and myself to which profile we are and why that was such an interesting thing. I think it's to the point, to your point, we are becoming even more individualized, but at this point we are, based on the geographies we came from, still quite similar. It's kind of like someone made the analogy for my time one time. It was like the social, like the Myers-Briggs or different things like that. We're all still kind of individuals socially, but that grouping does have some benefit in certain ways, and these can do that as well. The other thing I'd offer before I dive into them is this analogy notion of, it's an airplane kind of analogy. So the right airport, the right plane, and then the right seat. So I think what happens a lot right now is we're all talking about the right seat, why the window seat is better or the aisle seat's better or whatever. And we haven't yet stepped back up yet to see if we're even on the right plane or even the right airport.
You should have done that before you got on the plane, Brad. That's why to find the right gate and the right planes.
That's right. So in this analogy, I would suggest that the archetypes, the idea of the archetypes as a model, would be related to the right airport. If we are okay with or accept the notion that we come from these geographical points, environmental pressures, etc., 200,000 years, there's some relevance to it. Okay. And then if we could take the next step, which is the right plane, and that there's reliability and evidence that there can be 5 different archetypes based on genes, that's the right plane. And then the right seat is just fine tuning. And I'd offer that the advantage to this is that right now, in many cases, I use continuous glucose monitoring as an example, and I like the CGMs, and I do use them. They're reflective of how we respond to certain foods and activity, and it's good. But right now, we're using them like we're throwing stuff out there and seeing what happens. So how much stuff are we going to throw out there to get a reading and just to see what happens? That's what happens currently with like a CGM. What this can suggest is with your profile and your gene makeup, it's giving you a forward prescription. So it's telling you, for example, have the particular genes where your pancreas doesn't produce as much insulin. And it didn't need to, because you have the genetics that also came from Native Americans, like the Pima tribe. So they didn't need it. You don't produce it. And obviously, if you throw a lot of carbs in there, it's going to be problematic. But if I run your genes against these archetypes and can help you find the right plane, the right airport is just accepting the idea. The right plane is finding the right archetype. And I can find the right archetype for you. I can tell you where to go forward, and you're going to be very successful without a lot of guessing. And then the CGM is just going to be kind of fine tuning for your particular case. For example, looking at dawn phenomenon or cortisol causing your glucose levels and things like that, rather than trying to find what's acceptable. So I think that's a huge benefit.
It is, and I agree, but I don't want us to stop there. I think that is why I use the word is a bit lazy to say, okay, we have this archetype. And again, you can look through science. We get to something and we're like, there's gotta be more. Either we discover something by accident or there was some purpose behind it to study more. Yes, we have these 5 archetypes, which is great, is glorious. It groups people. But again, let's not stop there because
Right.
to be honest, we don't all perfectly fit into those 5 archetypes.
That's
So let's continue this thing so we can get to a place where we can seamlessly either treat people or support people, depending on what journey they're on. So yes, right now we have the 5 and we have the 5 to work with, but let's not just limit to that 5. Let's continue understanding that we're not a monolith. We talk about, 5 generations out to be completely mixed. People are going to be mixed and we're going to need to treat them appropriately. You talked about the quitter and we're having multiracial families. So what if somebody from Sweden marries somebody from Nigeria? Those children are going to have a combination of those, DNA makeup. So what may have worked for mom or dad may not seamlessly work for them. Wouldn't it benefit them to also find a mix and find them their own box outside of the 5?
Right.
Right.
Yeah.
Right. Yeah.
Right. Yeah. So they're actually in the world of genetics. There's a couple companies that are in the process of that. They're looking at what you would call traits. So there's trait, and you run all the genes, and you would find traits. And to some extent, I've kind of leaned into that. So I look at the traits related to insulin function, the trait related to glucose function, the trait related to fat metabolism and utilization function, and the trait related to its hypermetabolic outlier, but hypermetabolic high metabolic state function. So it actually, right now I'm looking at it by trait, which is where things will go, is they'll look at individual traits. Like, for example, you could even say like cholesterol levels and saturated fat. So that'd be a trait at a very finite level, which actually I do look at that too. So you're absolutely correct. There will be a trend here. We eventually, as I see it, there will be total mixing, and then we're going to start to, I think, look at traits, and that's kind of already happening. So would you be okay if I kind of glance through the archetypes real quick?
Right.
Okay. So this first one is a carbohydrate efficient metabolizer. So these people are best suited for higher carbohydrates. They have the genes that allow them to best use glucose. So I'll give you a couple quick examples. I'll give you one as an example. So there's a gene, it's SLC2A2, and it enhances glucose sensing in the liver and pancreas. So that's just one example, but that's how these profiles work. There's another here like ADIPOQ, which boosts insulin sensitivity via adiponectin regulation. So that's the nature of the genes and how they make up these archetypes. So these people do better with carbohydrates and not so much higher fats. From an evolutionary rationale, these people are from populations adapted to agrarian carbohydrate-based diets where consistent starch intake drove metabolic efficiency. East Asians, some Mediterranean groups, and some South Indians, as an example. And in those regions, the carbohydrate-based foods might be grains, fruits, tubers were abundant. So you can see how that might work.
Right.
This next one, which a lot of people may be more familiar with, is called the fat-adapted metabolizer. So this is around hunter-gatherer resilient people, and it's best suited for low-carb, high fats. So population people might be most familiar with are the Inuits in northern Canada, with eating fish, walrus, and fats. Also, like the Maasai tribe, if you think of them in Africa, who drank the milk and the blood and ate the cow, they lived in that sort of thing. So an example here with a couple of genes, just for conversation, CPT1A facilitates the transport of long-chain fatty acids in a mitochondria for energy production. Another is HADH plays a role in the breakdown of fatty acids within the mitochondria. So you can see with those genes, it facilitates a better fat metabolism. Yeah. And again, the evolutionary rationale is people found in Arctic populations. I mentioned the Inuit. I mentioned the Maasai tribes, for example. Northern Europeans, too, perhaps Vikings, who knows. But so you have here, their bodies are adapted to relying on fat oxidation rather than glucose. The next one is a dual fuel metabolizer. So they're metabolic hybrids. They're best suited for mixed macronutrient, not extreme carb, not extreme fat, but mixed in cyclical patterns, perhaps. And so these people have, say, the PPARG gene. It supports fat metabolism and insulin sensitivity. lEPR helps regulate fuel sensing and energy partitioning glucose and fats. So that's kind of a couple examples there. And the evolutionary rationale is this archetype may have evolved in migratory or seasonal variation environments found in populations of both hunting and farming traditions, such as many European, Middle Eastern, and South American indigenous groups. As an example, traits are valuable in environments where energy substrates were unpredictable or variable across seasons, glucose and fats, for example. The next one, this is me and my wife. Actually, I should use this for last. Let me use that for last so I'm going to skip to the fifth one. And this is more not as likely or frequent. It's the hypermetabolic outlier. So this is based on a high calorie diets with higher carb and fat intake, depending on activity levels. So it's for individuals with extreme metabolic rates. So some traits here would be like UCP1, which promotes heat production by uncoupling the mitochondrial respiration to burn those calories off without actually the need for energy. Another would be DIO2, which converts thyroid hormone T4 to active T3 for faster metabolism, for example. So the evolutionary rationale here is that it emerged in populations exposed to cold climates, elevated physical demands, and environmental stressors that are selected for high energy throughput or thermogenic efficiency, common in perhaps high altitude populations like Tibetans or Andeans, endurance-based cultures, and some Northern European and African populations, for example. So they're not as frequent. Now I'll come to the last one, but this is where I fall, and this is where my wife came into, which is an interesting, important contribution to this, where she came from to get here. So this is a carbohydrate-sensitive fat store. And these are people are insulin-resistant prone. So it's best suited for low to moderate carb and high protein diets, but it's not high fat. Remember, we had the fat adapted? Mm-hmm. They're not high fat. They don't have the genes for high fat, but they don't have the ability to accommodate a lot of carbohydrate. So these individuals carry genes that make them more likely to store energy from carbohydrate as fat and struggle with insulin resistance when consuming high carb diet. So think of the Pima tribe, seasons of feasting and fasting. All of this, we could look at that and say, well, that's a problem. Well, for where they came from, it wasn't a problem because it was feast and famine. And so when they had feast, they ate, they put on a store a little bit, et cetera, on purpose. So when there was famine, they had the reserves to thrive and survive. Pima tribe is one, some Pacific Islanders are some others. So the genetic trait here, for example, TCF7L2 is linked to poor insulin secretion and higher diabetes risk. The gene FTO is associated with increased hunger and fat store. So this archetype reflects genetic adaptations for survival in environments with scarcity, cyclical food scarcity, favoring energy storage from carbohydrates. It's most common in indigenous populations of the Americas and Pacific Islands, where these traits also present in some Southern and Eastern European groups, for example. So here's the thing. This all came about for me towards the end of January and beginning of February. Before all of this, remember, we had my wife. She was type 2 diabetic, size 16, etc. And what did we do for her? We kind of fell into it. We put her on a ketogenic diet because that's what worked for me to lose weight. I knew it was very efficient, so that's what we did. And that's where she got to. And oh, by the way, we found that it actually managed her glucose levels. And she came off diabetic medications. That was like wow, imagine that. And so sort of a surprise benefit. Over time, I just started to think, I don't think you're broken, Diana. I really don't think you're broken. We made these changes, yet all of your health markers are better. You have high cholesterol, LDL cholesterol, but your HSCRP is 0.6. Your OXLDL, a marker of oxidation of LDL, is way into the optimal green. Some other metrics, like one is this, I actually don't know the full name, and folks might, but for example, your MPO, marker of microphage activity in the artery, if you have atherosclerosis going on, way down into optimal. Another being LP, that's LPPLA2, is associated with soft plaque activity. Hers dropped down into optimal. It got better. So if all of this LDL thing is a risk, why is her MPO and LPPLA2 getting better? Why is her HSCRP optimal? Why is her oxidative stress so low? I don't think you're broken by, the references we have today. I think we need different references. Mm-hmm. And so we were fine with that. She just did her thing. And then January came along. I built these profiles based on evidence that I had. I ran her test, her genetic test, her report. I have it up there as a sample report on my website. It's actually her report, but no HIPAA here, so she doesn't mind. So it came back, and you know what? She had the gene variants for TCF7L2 linked to poor insulin secretion and higher diabetes risk. And several of the other, she also had the FTO gene, which encourages more fat storage. She exactly fit this profile. So it was like reverse engineering. I mean, it was totally unbiased. I mean, we didn't try to make it work. We just had, this is what we did to help her get healthy. Along came this concept. We just threw her genes against the model, and it came back and said this. And all that did was further substantiate for me that she's not broken, and she can be totally healthy when she gives the genes what they need. And so I've done reports for I guess 7 other people. I did it for myself too. Now I don't have the gene, the TCF7L2, for higher risk diabetes. But what that is the pancreas isn't geared up to produce as much insulin post-prandial. That's what that is. Okay. So I ran it for myself, and my insulin trait is low, not quite as low as hers, but low. But it's related to the insulin receptors. I have within the insulin system, I have a slightly different issue, but it still affects and puts me into this carbohydrate-sensitive fat store place. Now, here's the thing. My dad, he was a smart guy, went to school, went to Maine Maritime Academy, piloted the boats, the big banana boats, the White Fleet, brings bananas from South America. He started his own business, but he had significant central obesity. And later, he had triple heart bypass and carotid artery surgery. Now, just to help people understand, he tried to communicate that he's a smart guy. He wouldn't do anything intentionally that didn't follow the guidelines for what to eat and such. He ate good foods. He did have potatoes and meat and vegetables. And my mom was a nurse. She was a registered nurse. So between them, they would follow what the guidelines were. Central obesity, triple heart bypass, and carotid artery surgery. I don't have any of that. I have his genes, but I don't have any of that. And when I ran my genes, it came back as this carbohydrate-sensitive fat store. So again, like my wife, unknowns to myself, I adopted my wife's approach for nutrition. I didn't know that I needed it, but it was just easier cooking in the house.
But you also get genes from your mom too. So could it be that your mom's genes are more dominant in your presentation?
Yeah.
So just going back to the 5 modules you presented, there's something that was glaring, which makes my point. Or you emphasized the point that I was trying to make earlier. You ran through the profile, and please correct me if I'm wrong. The profile that matches yours and your wife was number 4, and then what you read number 5 first. All right. So the glaring thing I see with this module is that granted 5 profiles are presented, however, only one. And the last one at that even mentions Africans, and it says it's a rare occurrence. So this is what I'm trying to emphasize here.
You're there. That, and I don't know, you may be 100% true on that, but that is not the full list of all.
Got it. Yeah. So I think for anybody working on something like this, and you too, this is just coming from lived experience. It is very important that if something doesn't fit or doesn't have inclusivity, that people are not included or waste their time, because this is what happens most times in healthcare or wellness, where people are actually seeking to do better for themselves, and they go to practitioners that are not familiar with treating them or do not have any reference point about treating them, intervening, supporting them, whatever it is. And that wrong. I'm not trying to sugarcoat anything. The wrong module or the wrong recommendation is used for them. And sometimes it can end up with a long-term injury or even fatality.
Yeah.
This is what I said. We have 5 modules right now. There's a lot more to do. There's a lot more of discovery to make. There's a lot more of inclusion to be had. Because if I were just listening, because we have a lot of people listening, if I were just listening, it would discourage me as a person who's trying to make a change. Like, I really didn't hear myself in all of those profiles, which is why at the end of this, I will ask that you provide our listening audience with your website so they can go and read and study for themselves more extensively so they can make more informed decision on working with you, because I really do want people to listen to what we're discussing and reach out and work with you should they feel or see themselves fitting into any treatment recommendation. Because when we talk about distrust in healthcare, it's a history of it. There's a history where Black and brown people do not trust the healthcare system because, again, there's a history of mistrust and mistreatment and maltreatment, whatever you want to label it. So listening to that without seeing the full website or full profile, that is what that read to me. And that is why I made the statement earlier. We're not a monolith. We're very individualized, and there should be room to at least reflect us. It doesn't matter you're blue, green, yellow, purple, whatever shade of color you happen to represent. You should see yourself in your treatment. That's
absolutely. Absolutely. Yeah. Very good.
So I thank you. And also, before we move forward, where can people find you, Brad? People that are listening to us and they're like, okay, I'd like to read more about those profiles to see how it can be helpful. Where can they find you? Socials, website, all of that stuff.
Sure. So all of my social handles, if you will, are at Hormesis Jeff. So that's HORMESIS, Hormesis HF. So they're all the same: Twitter, Facebook, etc. I have a coaching website, and then I have set up a website specific to metabolic archetype. So you could go to either. I get messages from either. If you want to really focus on the archetypes, go to metabolicArchetype.com. Metabolic Archetype altogether.com. And there's a menu at the top, metabolic archetypes. You can go down that and explore it. There's a tab there for why metabolic archetypes, which is also helps with foundation and such, and can give some good background. And if it sounds interesting, by all means, I mean, just on my coaching website, which is hormesishealthandfitness.com. So that'll take you to my coaching site. You contact me through that and get me that way. And so, by the way, if you go there, I mean, I think there's a pull down for a complimentary appointment. If you wanted more information, just shoot a message, and I can help elaborate on this without any commitment to help you further understand.
Absolutely. That's beautiful. And that is for both our United States and international audience?
Yes.
Beautiful. So this was a really interesting conversation and a much needed conversation. We've gotten used to the one size fit all approach to treatment and managing ourselves. It is necessary to know that you can actually pinpoint down to your individualized need to get that support, whether it's medically or holistic or integrative approaches, which also includes food and nutrition. So it is important. It's long overdue. But I thank you so much, Brad, for being here, educating us, having this conversation and answering questions and, giving your opinion and things, and not just opinion based on your expertise and experience as well. So I thank you for doing the work. Something that I usually ask of my guests before we end our conversation is to leave our listening audience with either a golden nugget or a few golden nuggets. What would you like to leave our listening audience with, given this conversation we just had?
Okay. So maybe a couple.
Okay.
And this is just from what I've experienced, to a large extent, not to be critical, but from the heart. When I say coming from the heart, I mean how much I care for my wife, how much I love my dad. So I would say we're at a point where and this is strong language, but do not abdicate your responsibility for your health to someone else. Take their insight, take their education, take what they have to offer, but do not hand over your health arbitrarily to someone else and engage in it. Because like many say, the health is the one true thing you have to protect. Recently, I saw when you have health, you have many things to worry about. When you don't have your health, you only have one thing to worry about. And we don't want to be there. There are some very different conditions that are very complicated, may not even understand yet, that require special care. But chronic disease, and I mean like PCOS and obesity and type 2 diabetes and even migraines and all these various things, they make up roughly 80% or more are related to lifestyle. And so I reached a point for myself with my wife that I just felt she was not broken. So for a moment, just consider maybe you're not broken. You're just not aligned with what's optimal for you, and seek that out. That's what I would say.
Thank you. Thank you. That is so important for our listeners that have been here a while. That's the one thing I repeat. You are the driver of your health. Get in that driver's seat. The doctor depends on you and your report on how your body feels to treat you. You are unique. You're just one person. Just because a provider of any caliber has an experience treating somebody of similar presentation does not mean that person is you. You are one of one. Advocate for yourself. If you want to do better, there's something within you that is asking you to seek alternative or extra support. Do it. All right. And if you can narrow it down to not go to the gym and feel like nothing is working, why not? We're all very unique. What works for me may not work for a sibling, a cousin, you name it. So take care of yourself. That was great advice, or that was great nuggets, I will call them. Two very shiny, beautiful nuggets, Brad. Thank you for leaving us with that. I really thank you for being here. I'm grateful you made time to be here.
Yes, thank you very much. Enjoyed it. Thank you.
Thank you, me too. All right. Thank you, everybody, for listening, and take care of yourself. All right. Bye-bye.
Thanks for tuning in to Unshelling Medicine podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.